Hello and welcome to the Pediatric Network. Today we're going to be having a chat with Dr. Matthew Doyle. Dr. Doyle is a chiropractor from Brisbane in Australia, and we're going to be having a chat about his latest publication in the Asia Pacific Chiropractic Journal. Now, this publication follows the progress of a 5-month-old female in his practice who had plagiocephaly. This little girl was treated with manual therapy as well as helmeting therapy. And the conclusions and discussion are very interesting because bring up a couple of really interesting questions about when those two types of modalities are used. We're also going to be talking about the necessity for a well-structured case report in the literature. We're going to be talking about plagiocephaly itself, the terminology, how to measure a plagiocephaly, the developmental issues that may accompany a positional plagiocephaly. We also talk about the effect of helmeting. We talk about the effects of manual therapy. And at the end, we have a nice little roundup of what you can take from this discussion to use in your practice tomorrow. So please get yourself comfortable and you're in for a treat. Here is Dr. Matthew Doyle. Hello and welcome to the Pediatric Network. My name is Mike Marinas. I'm your chiropractor and host here for All Content Pediatric. So today, very excited to welcome Dr. Matthew Doyle to the Pediatric Network. How's it going, Doc?
It is excellent. It's a pleasure to be here.
Wonderful to have you on. And the reason we have Doc on today is we want to talk about a paper that he published quite recently in the Asia Pacific Chiropractic Journal titled Improvement in Plagiocephaly, Cervical Range of Motion, Primitive Reflexes, and Subjective Parental Feedback in an Infant Co-Managed with Chiropractic Care and Helmet Therapy. Now, this is a case report and review of the literature. And before we dive into it, thank you, Doc, for putting out research. This is what it's all about.
Absolutely. It's one of those things that I recall hearing as a student and then as a practitioner going to seminars, if every practitioner published one paper a year for their career, like if everyone published or had to go up publishing one paper maybe every 5 years or 10 years, we'd have such a plethora of case studies and case series and commentary and feedback and perspective that would really help, build the evidence base.
Yeah, it's about putting that in and getting your experiences down on paper. Very, very important. Okay, and that's exactly what's happened here. And let's talk about in the beginning, before we even dive into the paper, because it is a case report. And I know a lot of the time people go, oh, case report and where it does fit into in the structure of evidence. Let's talk a little bit about why it's so important to have this well-structured case report.
So I think when you're looking at clinical practices, particularly in manual therapy and in professions like chiropractic and osteopathy, Chinese medicine, nursing, midwifery, like there's a lot of hands-on interaction with the people you're taking care of, and I think that's where there's sometimes the weaknesses in aspects of your randomized controlled trials where you're isolating that one variable. Every patient encounter we have there's so many variables that we deal with a baby. In this case, like a 5-month-old, you've got a mum and a dad, and you've got, are they working? Are they not working? What's their experience with chiropractic? What was the parental health like? What was the delivery like? There's so many factors that come into it that aren't controllable. So, case reporting, I think there's a real drive to understand its value in those clinical professions. And I think the way a lot of clinical professions are looking at case reports, when you can start to build a volume of well-structured data, is that it helps shift information on best practice and sharing practitioner experience into a much broader network, a global perspective, because we can share that literature online much more effectively. And I think that's the important aspect about it, is that it's well structured. There's been guidelines now since 2013. They published care guidelines for a quality case report. There's a paper in 2017 that a long list of medical practitioners published that gave really clear examples of each of there's like 13 different points with subheadings for how to effectively structure a case report. So that's the structure that I used for this case report. And and previous ones I've co-authored, and how I would encourage people to use the same kind of structure when they look at reporting whatever cases, adults, kids, pregnancy, geriatrics, whatever sort of case it is, because it gives a sense of aboutness where there's similar concepts and topics that hit with each of those case reports, so that you can start to look across information to see where commonalities are from a clinical standpoint. It's a very useful approach.
Yeah, I think one of the things that puts people off a lot of the time is it looks like a mountain when they think, oh, I've seen something really interesting in my practice. I've got the information, I've got the data, I'd really like to write it up. And then they kind of go, oh, how would I even start? And I suppose that's where to interject right here is you start with the care guidelines, because there are guidelines that are right there to be able to do that. And you're firing my neurons here to think that maybe that is a future discussion, as just a basic introduction to your practitioner to go, listen, you've seen something interesting in your practice. These are the first 3 or 4 steps, and then we can move you along. So maybe that could happen.
That's I mean, there's a whole, like, I've done a bunch of steps on that, which I think it's easy to dive into, but it's easy to spend another hour on that too. So
yeah. Absolutely.
Bookmark that for another chat.
Absolutely. So now we want to speak a little bit about this paper that Doc has published. Okay, so first of all, there is a link underneath in the comments wherever you are reading this. There's going to be a link to this paper, because it is free for you to be able to access, which is really important as well, because it doesn't help the two of us sit here and we talk about a paper that you can't actually physically get in your hand. So from Asia Pacific Chiropractic Journal, but we will put the link into the comments below. So Doc, before we get into some of the nitty gritty, and there's a lot of points we want to cover here, let's just give a basic outline. What happened in this case that you reported?
So it was a 5-month-old infant. They were referred to my practice from a colleague who'd been seeing mum in the city practice. They wanted more opinion from someone who saw kids a bit more. And so they're looking at shared care for a bub that had started to show a fairly severe plagiocephaly. That had a couple of adjustments. They came in, like I still take care of them on a semi-regular basis. We saw them a whole bunch over the first year, but did appropriate measurements through that time frame, so we can really track their progress effectively. There was the main kind of complaints Bub had. If we look into the sort of history there was issues with head asymmetry, poor neck movement, some issues with digestion. They were going away for a holiday. They wanted to get some work done before they went, and they were concerned with what was developing. So that was the start of it. Mum had a bit of a rough trot. Had a fairly severe hyperemesis through pregnancy. Been hospitalised. She had a history of scoliosis. She had some medication usage. Dad had thalassemia minor. There's a few things there. One of the big things they reported that there was not a lot of movement in the last probably month of pregnancy, and then in labour there was gas and epidurals. There was a vacuum extraction for a vaginal delivery. It was only actively pushing for about 4 hours. And Bub was relatively alert at birth. So, and had jaundice for the first few days. That was the start of things, and we kind of went from there. So, I guess one of the issues with positional plagiocephaly, it's got a number of different names. They call it, non-synostotic deformational plagiocephaly, non-synostotic plagiocephaly. There's a range of terms. The ones I use positional plagiocephaly in the titling for here because that's what the most recent synthesis of systematic reviews that Elwood, Draper Rhodey, I know Dawn Carnes, who you've had on here before, had just completed. So that was the terminology that they were using in their sort of highest level evidence review at this point in time about it. And one of the fascinating things, just diving into the literature again around it, they talk about before 92, it was estimated at the positional plagiocephaly being 1 in 300 infants. And now the estimates, they said between 16 and 48% of healthy infants under a year, or 37.8% infants between 8 and 12 weeks. But that before 92, it was 1 in 300. So now they're saying 48 to 144 per 300, or 113.4 per 300. That's a massive change.
A huge change, yeah. I wonder what could have happened around that specific time.
Yeah. And look, there's a whole heap of papers across a range of professions that talk about the back to sleep campaigns in terms of SIDS, and that is what it is. So there's a lot of other things that tend to come into it. I mean, I know your paper you have published in the Journal of Clinical Chiropractic Pediatrics was great, looking at some of the potential issues that can arise with more severe positional plagiocephaly. There's some issues with movement control, motor control, sometimes learning development, depending on which paper you look at. Some were quite significantly linked, some weren't. So it's a case where there's things have been shown in multiple cases, and now in some higher quality evidence to have quite an impact on the infant's development.
Yeah, there's a huge amount out there talking about developmental issues, and this range of developmental issues that you can get off something like positional plagiocephaly. And they range quite a bit, and I suppose it's because it's almost hard to tell, because you're trying to link back. You're trying to almost look forward and say, well, at 5 years old or 10 years old, this is going back, and then linking back and going, well, yes, they had plagio, they didn't. And then there's so many other things that come around with those. Like, we know that a lot of the plagio cases have torticollis with them. We know that a lot of them come with hip dysplasias, a lot of these other packaging disorders. And then can we just link it to the one? Is it the fact that this one has definitely caused the problem? Was it another problem that caused the plagiocephaly? They're all backwards and forwards with each other. So it's a little muddy when it comes to those. Having said that, the developmental issues definitely link up with that change in head shape.
And I think that's one of the powerful things that chiropractic care, and I comment in the paper too around the similarities between osteopathic care, a lot of craniosacral work, but particularly osteopathy and chiropractic in those early years. They're very similar techniques, very similar forces being utilized. Looking at cranial systems, spinal systems, pelvic, adjustments, and that to have an approach to looking at the mechanics of the spine and the cranial system that has the potential benefit to improving developmental outcomes, which at the same time has, relative risk factors that are so low, and in time a cost level that's quite low as well. It makes a huge amount of sense to use something conservative like that, at least as a trial of care for a period of time, to see if there's a positive impact that can be shown, which there's a lot of case series and case studies that have done that now.
The evidence base is definitely, as you talk about in your paper, is growing, which is wonderful, and it's because of people like yourself that have an experience and put it down, and then people that take that information, synthesize it, and then we start coming out with the bigger picture of what's happening. Now, we talked in the beginning about the fact that plagio comes with a lot of different words, a lot of different ways to define it, but it also comes with a lot of different measurements to get this this cranial vault index and those kind of things. Can we just run through, because I know you run through it in the paper, what kind of validity is attached to what kind of methods?
The ones the paper that was probably best, that looked at the ones that were most useful in chiropractic practice or in sort of manual therapy practice, was done by Siegenthaler when they were going through the ACC, and they looked at 6 major measurement tools,
Mm.
and they found there was evidence of some reproducibility and reliability with all of them,
Mm.
but there becomes some issues. There's visual assessment, which is, a clinician can eyeball things and say, yep, that's a flat head. That's a bulging fontanelle. That is translated forwards, but it's not as accurate as taking some form of measurement. There was the measurements with the caliper, just a plastic caliper or a steel caliper. That seems to be relatively reproducible and reliable, and it's low cost and it's low tech and it's efficient. And anyone that spends any time looking after kids, you have this much time where you've got a compliant person in front of you who is happy enough for things. So that seems to be an effective way of doing it, which I prefer in clinic. There was a number of other ones too. Your three-dimensional photography, radiological imaging. You try and avoid X-ray imaging at that point if you can manage it, accurate as it is. The 3D imaging is more specialized. This bub had seen, to get the helmets done, had seen someone that did the 3D imaging. And so they had some images with that, but then there's a number of different systems you can use, and there's not as much as I could see standardization, and the cost of that sort of equipment is astronomical compared to, like a pair of the Mimos calipers that you just go, flip. Oh, yep, there we go. We've got 155 mil or 145 mil. So yeah, that was an interesting thing, diving into the literature around what was the balance of being reproducible and reliable, but cost efficient for the practitioner to get and utilize, and effective and time efficient to use to check the bub's head.
Yeah, I mean, you make a very valid point there, because you could get a system that is highly specific that no one uses, because it takes 3 hours and we have to drive them, an hour to go there, and no one's going to go through that. Then you can get a system like the calipers that, as you say, you can sit bub down on mom's lap, you go one side, you do your little calculation, and you can come out with something straight away. And what's nice about that is that you can then, the next time they come in, you can then go, let's do same thing again. Let's see where we are. And I think, not just putting off, like, practitioners might end up not doing something because it takes a long time and it's upsetting to the child and that kind of thing. So if you have something that's cheap and nasty is the wrong way of saying it, but is easy enough, is accessible enough, and it's not invasive, then you have to weigh the pros and cons and then come out with something. And in your research, you kind of came out with going, look, it's a decent method, those calipers, which is a nice take home for practitioners watching.
And it's easy to calculate, like your cranial vault asymmetry. It's literally you take the small one from the big one, and that's the difference. And then the index is where you then divide it by the big number again and multiply by 100, and you get a percentage. So it's a really simple calculation to do on your iPhone or on your computer in front of you. And then within the literature, there's the actual specific sort of ratings where we had, what did I put there? There's, your normal was within 0 to 3 mil, mild was within like 3 to 7%, moderate was 8 to 12%, and severe was more than 12%. Yeah, so it's relatively quick to do that calculation. So this bub was at like 14.8% or 14.3% at the start, and went down to a 5.3%. So it went from a strongly severe rating down to a mild rating over that time frame. So at least it's a big enough shift to say, well, there's something positive's happened there.
Yeah, no, absolutely so. And so important to measure these things, because, as we say, eyeballing is one thing, but where's your measurement? How do you know what you've done if you haven't taken a measure of it to be able to tell? So that is fantastic. So it's nice to know that you get methods like that can be used straight away. Now let's talk a little bit about, because working in the office is fine, but we spend this much time, and then parents spend this much time with their children. Things like tummy time for plagiocephaly? What's the outcome of that? Is that something that people should be doing at home?
Yeah, absolutely. So that's one of the really clear things I think in the literature, and um, I think if you even stepping back just from a human being on the planet dealing with gravitational force, if you're an adult, everyone hears about posterior chain exercises. We've got to do kettlebells and thrusters and burpees and all sorts of things to build that posterior chain. An infant comes out in more of a C shape, and like it's so important to build that posterior chain strength to give them head strength, neck control, secondary curvature development down the track. There's things that are important that the parents can help with. Now, particularly in plagiocephaly, what seems to be reported by a lot of the more experts in the area, I quote Joyce Miller and Sharon Balone from a paper 10 years ago that talked about the importance of tummy time. Now, those women are amazing. Joyce has got a PhD in looking at kids in chiropractic and have published hundreds of papers around kids in chiropractic. And their sort of recommendations, which is something I very much take to heart, was, they wanted to be doing at least 5 minutes of tummy time within the first week. Now I was explaining to parents, that doesn't mean 5 minutes in one go.
Yeah.
You're changing a nappy, it might be 10 seconds on their tummy and they might handle that sort. It might be 30 seconds. It might be, it's cumulative over time.
Yeah.
So that's sort of 5 minutes per week. It's about 10 minutes by a month. It was about 20 minutes a day by 2 months, about 45 minutes a day by 3 months, and about 80 minutes a day by 4 months. So there's a graded increase as the infant, and there'll be some slight variations based on were they a 30-week premature baby that spent 6 weeks in the neonatal intensive care unit with a feeding tube, versus they're born at 42 plus 1 and we're just about running straight away. There's going to be different levels of capacity that you've got to deal with mum and dad. So definitely tummy time's a big thing. And the other thing that I think that's hugely seems to be very beneficial is using like an exercise ball. That's a really nice way of introducing tummy time gently, having parents holding on the ball. They're going through gentle. You can take them almost into a vertical position. So there's very little load for extension where they don't have to work hard to keep their head up once they've got a little bit of control. You can then, particularly plagiocephaly cases, you can work in lateral movements and gentle, forwards and backwards and gentle rolling movements there for the infants, sensory motor integration and neuromuscular control of their proprioceptive systems to start to integrate that stuff and work a little bit. So those are things that I absolutely would recommend talking to parents about, and then get my parents to work with their kids from the start.
Yeah, super, super important. And what I really like about what you've done there is you've given times, you've given amounts, because I find a lot of the time you send a parent home and say, go and do tummy time. They're kind of, okay. People really need to be directed with this kind of thing. You get the A-type personalities that want to know, is it 4 minutes and 20 seconds and how? And you also get the other, which we like to call in South Africa, loscops, the people who are not too sure what's going on. They also need to be a bit sheep-herded, back in again to be able to say, no, it's this amount then. And they're kind of, well, I did a little last week. And you go, no, that's not tummy time. And to be able to give them a framework within which to work, I just find that works so much better for the parents. Less guesswork on their part, I think, which is really, really important. Speaking of guesswork, and how we don't want to do any guesswork, when helmets are used, let's frame it that way, because the really interesting part about this case report and lit review is the fact that you're not talking about one modality here. You're talking about chiropractic care, but you're also talking about it used in context of the child having been helmeted as well. I think that's one of the things that really gripped me about this paper, is it's a real life situation, because that is a real life situation you're going to come across. A child is going to be helmeted for this kind of thing, and then to kind of go, how do these two mix with each other, which is a lot of what you talk about through the paper. What are the different questions that raises? What are the outcomes that we can show from these two working together? But the fact that we have used helmets as well, can we talk a little bit as to the timing of using helmets?
Yeah, so like I'm not definitely not an expert in that area, but just reading into the research for the paper was great. You know, like the Elwood and Kahn's paper talks about that. You know, there's for positional plagiocephaly, they found there was positive low-level evidence of improvement with helmets, and they found there was moderate positive improvements with manual therapy. So like there was an interesting mix there. One of the papers that I looked at from Korea had done a retrospective series of 108 people, 108 kids who they generally wanted to be they got best results if it was somewhere from about 5 months onwards, 4 to 5 months, and they found there was quite a significant drop off in the degree in the level of cranial vault asymmetry index change if they started at 9 months or beyond. So you kind of got that, and usually you've got your posterior fontanelles fusing up within the first few months. Your anterior, you're starting to get more of that, sometimes 9 months, sometimes 15 months. Like there's quite a range there. So I think there's got to be something around the structural mechanics related to that. Yeah. And it seemed to be, they recommended about 7 months was the more optimal time frame. So you start them at 4.5 or 5 months and go till sort of 12 months. That's where those sort of papers seem to get their more optimal results. But if it was much past 9 months, there wasn't a lot of change that was occurring with the helmet therapy.
Okay, so very interesting to dive into the research there, just to see what the research has to say about that. Now, let's get into the waters of the actual chiropractic care when it comes to these children. Now, the issue comes into, as it usually is, what are we aiming our manual therapy at? Which area of the child are we working on? How many treatments are we working on? Because the problem is that does become quite important in a prognostic way. Because it's very important to be able to say to a parent, look, this is the road that we're about to travel. This is how long we're going to be involved with each other for. These are along the road, these are the waypoints that we're looking for. With your look into this literature review, what can you tell us about timings and how many treatments and what kind of treatments we're looking at?
So it was very varied.
Just to drop the whole bomb on your head.
Yeah. So this is the one true way. Follow the gourd or the sandal. I'm not sure which. Monty Python references always go well, right?
Oh no, it went down well with me. I was still laughing.
It was very varied. There was anywhere from 1 visit to kind of 30 visits. There was one that had birth trauma reported with plagiocephaly visually without any measurements, but it was literally a 6 hours old bub. They did a gentle cranial adjustment. The tone improved. The feeding improved, and happy days. That was done at the very start. And when I went through some of the osteopathic literature, they've been involved in the neonatal intensive care units, and like they talk about going through and assessing cranial, cervical, thoracic, lumbar, pelvic, limbs and organs, or abdo and thoracic cage. So there was one visit. There was papers from the US of kids that were about 2.5 months old each. They all had variants of techniques like Logan Basics, so doing gentle sacral apex contacts with gentle feeling up through the lumbar, thoracic and cervical spine for releases, some cranial work, and the cervical adjusting was sort of more of that touch and hold, sustained contact, eyeball type pressure. Those were anywhere from twice a week for 12 weeks and 3 times a week for a month and 3 times a week for 20 visits, so that was varied. There was a 4-day-old that had 6 visits over a month that was just gentle touch and hold techniques. Some cranial work, particularly with sphenobasilar work. That seems to be a common thread, is occipital sphenobasilar type releasing. So, and I put these all on a table because I just, when you again, this is where it goes back to structuring a case report. When you're starting to talk about things like consilience, which is where you're looking at common factors across cases that aren't exactly the same, but there's similarities in those. It allows you to draw a better picture of what's happening. Walker and Russell, they did 6 visits over 5 weeks, and then 6 weekly visits for 6. There's 11 visits in sort of 3 months. Mostly, some, and that was quite varied. Some was sort of like a PI ilium, some was an ASR or an Atlas listing for touch and hold techniques. Gordon, who's in New South Wales in Australia, looked at a retrospective study of 23 infants with an average age of 12 and a half weeks, and saw them, I think it was about 6.9 times was the average use. But that was mostly cranial work and pelvic work. So there was no cervical adjusting at that point. It's no cervical sustained hold contact work done.
Yeah.
But saw positive results. He also found that there was, even though it's a small case number, there was a big enough statistical difference between the infants that used one of the donut pillows as a stabilizer compared to the ones that didn't. The kids that didn't use the pillow got better results, got a better cranial vault asymmetry index change.
Okay.
So that was a bit interesting.
Yeah.
Maybe there's something about being held in a position. Maybe there's something about having more flexibility to move as the infant's subconsciously doing stuff when they're sleeping.
Yeah.
Then there was probably the biggest study that had been done to date was with Joyce Meller and Douglas and Browning at ACC did, which was a prospective cohort study. So it's it was the highest quality study done to this point in time, where they said, right, we're going to do this test. They had a 6-week time frame to look at, because they thought, well, you're definitely mitigating natural history in that sort of case. They had 5 treatments over 6 weeks. They did primarily just cervical touch and hold techniques. So, you've got one study that's 23 kids, cranial and pelvic, getting good results. And then another one was 64, where they didn't do the cranials or the pelvic area. They just worked on the cervical spine and generally got good results. There was varied measurements, and I wish, I would love to see the literature kind of standardized for practitioners to use the calipers, because it's just, there's medical literature that's used that, and manual therapist literature that's used that now. So that would be I think a better way to go.
Yeah.
And then just most recently, Braden Keel and Christian Flutter had a paper published of 150 consecutive infants, and they saw that of those that had plagiocephaly, of the consecutive infants, 60% had plagiocephaly. So that's 85 of them had plagio. Of those, 92.2 had cervical range of movement restrictions. So they didn't go into a lot more depth of that, but so there was something common with restrictions in cervical range of movement, which is what I found in this case report.
Yeah.
So when it comes to saying this is the one technique to do, I don't know.
Yeah. And perfect. We own that. There's a lot of differing research out there. As you say, people getting positive results, different methodologies to get to that place. And I suppose it also talks to the fact that not all plagiocephalies are created equal. The condition itself, almost like a hip dysplasia, it's a range of different severities. And at the same time, you've also got people at home that are carrying babies in different ways. They are placing them down differently. They're sleeping them in different positions. They're doing much more tummy time, mom A compared to mom B. You know, there's a lot of difference inside there. But really interesting to see that there's a lot of variation when it comes to techniques and timings with the research.
And with the variation, it seemed that most of the literature showed the moderate to severe cases were the ones that had more commonly issues in some form of developmental delay of something, you know, motor control, learning cognition, whatever it was. The minor ones didn't show so much, you know, so there was kind of a sliding scale of the more significant the structural change, the more impact on functional expression of health was. Okay. And it's kind of the perspective I took after reading all those papers was, you know, from a chiropractic point of view, D.D. Palmer talked about tone within the nervous system 125 years ago. You know, perhaps with these, you know, chiropractic practitioners, they've got their own expertise in the way that they've been taught to assess an infant, you know, with age appropriate assessments and force delivery, and they impacted the system, whether it was cranial or cervical or lumbosacral, in a certain way, which may have allowed for a change within tension in the system. And then you know, one of the other theories that the New Zealand researchers looked at was talking about helping the cervical spine work better with an adjustment, so you had better somatosensory integration, which allowed for more normal, you know, forces within the structures durally, which may then have an impact on cranial formation. So we've got what we've got in the literature about, well, there's a bunch of positive outcomes. Mm-hmm. Now there's a lot of theories around how that may be reflected. Joyce Miller and Sharon Valone, I always quote their comment about, you know, we should be, yeah, look at what we confident, what we cautious in what we conclude, but, you know, but look at spread of what we theorize how it may work.
Okay. Yeah. I like that. It's a measured approach, I think, to things. And that's always just in a sort of a personal capacity. That's where the problem kicks in. The moment someone goes, it is this, you kind of go, you're either not an expert in your field, because all the experts I've spoken to, none of them put their head on a block, because they all know that we work in a world of percentages. In 30% it happens, you might be in 1% of the time it happens, you might be in that 1%. So for you, 100% of the time it's true. You know, so I think that's very true. Take this caution rationed approach. Take the literature, take your expertise, and as you talk about in the paper as well, take the parent's expectation, the patient's wants and needs as well. We put those three together, and then we come out with our evidence-based approach.
Well, and I think one of the, you know, goes back to, you know, a lot of, you know, manual therapy in infants, particularly, you know, chiropractic care, osteopathic care, it's very low risk, you know, and that's one thing we've faced in Australia multiple times in the last few years is the challenges to defend and to understand that those sort of statements better. You know, that the thing I love that the Victorian government has published the Safer Care Victoria findings, where, you know, there was quite an uproar last year around kids in chiropractic. So, you know, one of our states investigated this, and it's literally, I think, as far as I can see, it's the largest kind of patient satisfaction survey of its kind in the world. You know, they had a great opportunity to really find out if there was significant harm occurring with chiropractic care in infants. And, you know, they you know, I just quote some of these things here, like they did an extensive search for harm through a Cochrane Australia literature review that captured data from our national professional regulatory body, that captured claims data from the primary Australian insurance providers, and they had stakeholder feedback. So there was an opportunity for those that had purported to see harm to report.
Yeah.
You know, like that was what was asked for. They in a quote from their publication says there was no patient complaints or practitioner notifications that arose from significant harm to a child following spinal manipulation. And then they had a public consultation for parents and guardians that had accessed chiropractic care to, you know, talk about their experiences, both positive and negative. Now, there were some negative responses. You know, there was the negative responses were relating to, you know, no improvements with treatment, excessive use of X-rays, perceived pressure to avoid medications, or, you know, the advice given by other practitioners. Now, that was the negatives. The negatives were 0.3%. So 99.7% of those that answered, you know, had relatively positive responses. Now, it wasn't a small number. It was 99.7% of 21,824 submissions. Yeah. So you had 74 negative, and the rest were, you know, talking about things that spinal care helped their child improve after treatment. And the report specifically stated that it was clear the parents or guardians appreciated the time their child's chiropractor took to listen to the child's symptoms, engage with them and the child, and a sentiment was strongly expressed of the right of the parent or guardian to choose their child's care. And the parents or guardians reported that they accessed chiropractic care for their child on a wide range of conditions and complaints, including maintaining general health and well-being. And the most common conditions were posture concerns, colic, neck pain, difficulty with breastfeeding, back pain, and headache. Yeah. Now, it was interesting, just like in this case, it was because of the asymmetry of head. That was one of those complaints. But then there was also some digestion stuff. They noticed they couldn't turn their head properly. So this goes back to the importance of, you know, well-structured case reports to be able to collate that data down the track, because we're dealing with a multitude of factors in each individual that can have an impact on that. Just the breastfeeding aspect of it. I love that, you know, one of the practitioners quoted the complexity of breastfeeding. It's, you know, it's a synchronized event. This is from midwifery literature. You know, the breastfeeding is a synchronized event requiring the infant to suck, swallow, breathe. Performing this coordinated event requires 6 of the 12 cranial nerves, 22 cranial bones articulated at 34 sutures, and 60 muscles that are both voluntary and involuntary. Yeah, that's an amazingly complex, you know, piece of, you know, neuromotor integration for, yeah, someone that's been playing in the outside world for a very short time.
Yeah, sure. Absolutely. So much to get involved with. And I mean, a plagiocephaly, a change in the morphology of the skull, is not going to help that finely tuned neuromuscular event of breastfeeding. You know, potentially, I mean, that has the potential, let's say, rather put it that way, to put a lot of stress on something like that. So yeah, absolutely important.
Even when there's one of the other papers that I'd recommend people have a look at, that's again free to access, is the osteopathic paper I quoted, where, you know, it just had a really nice pictures and nice descriptions of how they went about their assessments. And it's a nice paper for, you know, manual therapy practitioners who are looking after kids and looking at co-managed care, particularly with, you know, talking to hospitals and bubs in an earlier stage, just to say, you know, to be able to take that to your case discussions with you know, pediatricians, OBGYNs, midwife groups, you know, just so it's another piece of nice level of literature that's been published in the osteopathic medical literature to help understand the process, because it takes away some of the fear and concern at times of, well, how do they do that? What do they do? Like it's nicely descriptive with good images to say, well, this is similar to how we would go through that approach.
And also, very much like when I spoke with Dawn Carnes, one of the nice things about that is that that's research that you can show that doesn't have massive investment in one type of manual therapy, because you're not saying it's chiropractic and this, you know, this is, and we're almost like you're not pushing a narrative. You're going, look, this is the research from within the bounds of manual therapy, you know, and this is from someone who doesn't have a vested interest in chiropractic doing this or doing that. this is just data, and this is true data. So it's nice to be able to pass it on without that almost inherent bias, if you like.
Nice. Well, so let's
Right.
put, I'd almost get to the, like the nuts and bolts from a practitioner. Like the editor of the journal did a nice job putting a little green box at the front of the paper that kind of had the main take homes. There's, tummy time's important. Talk to parents about that. Using the MIMOS calipers, a set of calipers to measure, making sure you're measuring the right areas, sort of here to the urion around the back on the contralateral side. That's efficient and has reasonable reproducibility and reliability. Usually you want to remeasure within that first 6 weeks. You probably want to look at, depending on the severity, 4 to 8 visits in that sort of time frame, so that you've got some capacity for impacting the tissues and the neural feedback mechanisms. And the change might take longer than that too. And in more severe cases, you absolutely want to consider working with other practitioners, particularly your helmet therapists, that can go into an orthotic space. That's probably something that we didn't really touch on there too. I think that's important, is because there's not, I hadn't seen any cases that published, well, here's co-managed care between chiropractic and helmet therapy. I looked at this almost a little bit like my, folks that I take care of doing prehab type work for knee replacements and hip replacements. The literature shows with some of those major geriatric orthotic devices, if the organism's in a better state before having a more major structural change applied, they tend to respond and recover better. And that sort of makes sense in the infant's case. It probably happens quicker. So there could be you could theorize that, getting adjusted, clearing some of those tension patterns may prime the system for more effective change. The infant in this case saw, fairly significant percentage change in a much shorter time frame than what some of the other case series had shown. It's an N of 1, so you don't know if that's just that's an outlier, but it was 4.5 months as opposed to the recommended sort of 7 months. So maybe something has to do there with the co-managed aspect of the care, and that's the sort of thing where you'll need more research to look at. Well, if we have case controlled matched, cohorts where you've got a couple of variants of interventions that are very low risk, your helmet therapy and chiropractic manual therapy, you can look at just one or the other, or one and the other, or timed interventions of each, to then track change over time. So there's some really interesting avenues for further research in that region.
Yeah, it definitely raises a couple of really, really good questions for research to follow up with. Like we were talking about before we came on here, when I work with my orthotist, the idea is to see them before, get work with them while the helmet's on, and then when the helmet comes off, make sure that we keep the mechanics working properly. Because I think sometimes, and not even think, I know this from a couple of practitioners I know, it feels like it's almost manual therapy and then it's the helmet. And then we have to, and that's not the case. That's not the case at all. They can work and mesh with each other really nicely, as in your case report shows that they come in way underneath the expected time of resolution.
Yeah, and look, we're obviously we're a biased discussion, given our nature, but I think it's a fascinating area to research.
Yeah. So, Doc, thank you very much for taking the time and putting your experiences down on paper. That paper is free to access, so we're going to put that link is going to be below. Check it out. As Doc says, some wonderful tables inside there as well, which you can just go through and be able to pick out what the commonalities were between these different cases. Also, a couple of really, really good takeaways we got here with the calipers, the timings, the kind of times you can give with the tummy time. So it's been really, really interesting, entertaining to have you on, Doc. I've wanted to speak to you for a long time. So yeah, it's wonderful to be able to see you face to face, and I'm sure we'll see you again here on the network.
I appreciate it. Look, and I tell you what, I appreciate what you're doing with that, because I've enjoyed listening to a whole bunch of the interviews and experts talking about things they're passionate about. There's always just those little bits you'll pick up that I've literally applied in practice. If other people had questions or things they want, I mean, my email address is on the paper, so I'm more than happy to respond to that sort of thing. And I think there's, particularly around case reports, there's probably more to be said and done.
Yeah, wonderful. So I thank you again very much for your time, Doc. Wonderful.
Thanks a lot, Mike.